And talk over. Aren't you a duck?
Shut up. That's so cute.
I love
Oh
it.
my gosh.
If I have something.
It's here. Where's I have mine going? It's okay. I will.
Sometimes you don't even know what the fuck it is.
You know what that
I'm just like over it.
it says configure stars.
No, it never does. Yeah, that would not be there. I mean, girl.
Okay.
I don't even know why I was bringing it actually. So
Okay.
it's fine.
She'll be like, all right, you guys remember Kylie, right?
What?
Because I tell them, you guys remember Kylie, right?
Yeah, that would be saying like, hi, like it's my first guest today.
Well, because it's 2:50.
I know.
Wishing her calls it comes. All right, we're gonna get started. We have our first guest today. Y'all remember Kylie, right? Literally somebody who's been with you from the very, very beginning.
I know. I told you to go by fast. You're almost done. And then you're gonna see me crying like a baby at Penny.
We all cry like a baby. It's okay.
Okay, did everybody see the announcement on clinical agencies about pinning? Did anybody not see it?
And I'm gonna take a second. For those of you guys who are like, I've already graduated, I've already crossed the podium once, blah, 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 I don't need to do it again. Garbage. Garbage, okay? You don't have to come to actual graduation. You have to come to pinning.
It's really fun,
Please,
actually.
please, please, please. It is so, we need you to come to pinning. The faculty, Kylie needs you to come to pinning because
It's my baby.
it is fraught with pomp and circumstance, and it is just,
And we're inside this year.
please
That's
don't
a
make
big
bad,
deal.
okay?
That's a big deal. So just to kind of give you information about what pinning is, kind of like our own little ceremony, our own little graduation, where I'm not a nurse, but the rest of the nurses welcome you into their club, basically. So
It's like the mafia.
yeah, like we even like do candles and like a whole oath, like you don't have to drink anyone's blood, but kind of that kind of vibe. Okay, it's actually really fun. So I'm just gonna go over a few things. We are going to be in Masari this year. We're not going to be on the football field. In the past, the football field has been great, but we fight the weather and all the things, and that's not fun. We used to be in the ballroom, but you have way too many people that love you, and we outgrew the ballroom and became a fire hazard. So that's why we ended up going to the football field, and now I've begged and pleaded enough years to let us use Masari. So we'll be down. Did any of you guys go to like convocation, one of those type of events where like they have the tarp on the floor and all the chairs? That's pretty much how it's going to be set up for our ceremony. So you and 2 humans, regardless of age, will be allowed to go and sit on the court.
Why do you have to say humans?
Because some people have asked if they can bring their dog to pin them. It'd be cute, but don't know how that would work. So,
Dogs don't have opposable thumbs.
yeah. Yes. It does not have to be 2. You have up to 2. But that doesn't mean you have an extra person to give to someone else who wants 3.
Also, if you don't have somebody, one of the faculty would love to pin you.
Anybody in the nursing,
Yeah.
school of nursing would love to do it. We've had that happen before, and it's not
So
a big deal.
not having somebody to pin you is not an excuse to not come.
Or even if you just want them to pin you anyways, even if you have them, like that's acceptable too. So after spring break, you will be receiving a form, Microsoft form. It'll ask for your name, information, and then you will list the people who are pinning you. So I think the example I have on there is like Chris Hemsworth, comma, husband. Regina George, comma, sister. Okay, so that's how you're going to fill it out because those people get announced. There is a spot for you to write what your name is, like on file legally with the university. I have to have that just for tracking reasons, but whatever name you prefer and you want to be called, there's a line for that. And there's also a spot for you to write it phonetically, because I know sometimes we have issues with pronouncing names. I went through it all through high school. My maiden name was Vukanich, and that got messed up a lot. And you can imagine how I got teased in high school. So yeah, all the things are there to make sure it's your moment. You've worked really hard, and whatever we can do to honor you in that moment is what we're trying to do. That information you send, there's also a spot where you could put like a quote or like a favorite nursing school memory. That will be on the slide with your picture that is up behind you when you're getting called. Okay, so it's actually really cool. Not to brag, but most people say simulation, but you know, whatever. It happens. And then that's most information on the form. The way it'll work is you will be given a ribbon when you come in that has a pin that was donated by the Alumni Association. It just says nursing alumni on it with a little thunderbolt. And when you get called, you'll be sitting in the order of the slideshow, and then we'll call you and be like, oh, Heather Kirkendall, thank you by her friend. And then they'll go like this, and then you stand, you take a picture, and then you walk. Okay? Pretty? Makes sense? Yeah. Any questions so far?
If you have a pin you want to buy,
yes, you can add whatever pins on there you want.
It does not have to just be this one. You can get a beautiful pin off of Etsy, or you can buy, I guess there's one in the bookstore.
They used to have one, but it was really ugly, and it was $60, and I don't even bother with that anymore.
There's beautiful ones on Etsy.
Yeah, Etsy, you can have them personalized.
Yeah.
Yes.
So can we only submit one picture?
Yes. Yes, there will be another link for like candid pictures. That will be like a slideshow that's playing as everyone's like getting seated and before the ceremony starts with like music and stuff like that. So I only request on those, do not send me pictures of Foley Catheter Day, please.
Unless you have it like blocked out by something humorous.
Because don't send
maybe a smiley face.
Any pictures that you would not want your grandparents or future employers to see. Thank you. Okay. The other reason why I have to say 2 humans of any age is because one year I had someone bring 2 family members and 2 children, and they said, oh, they'll just sit on their laps. Like, this isn't the airport. We're not doing that. Because then when you have, I'm not saying don't bring your kids. If you want your kids to come and be in part of your ceremony, awesome. But they have to sit down there the entire time. So that's where it gets a little dicey. Having a 2 and a 3-year-old sitting on people's laps in the middle of a 3-hour ceremony, I wouldn't have done it with my kid because he would have driven me crazy. But just use your judgment. You know your kids, you know your family, those types of things. We had a family member. There is what am I trying to say? Handicap accessibility. So if you have like grandparents or anybody that needs like a ramp or anything like that, we will be able, there is an elevator that goes down to the court, so then they can sit by you and we'll make that work for that. It's gonna be a lot easier.
Yeah, and then it's a ramp going up. Is this
I don't even think there's a stage, actually. It's just gonna be like a big area with a podium. Nice. Because the stage that they had for us did not have a ramp, and so we decided not to use it because of that reason, actually. But yeah. Any questions?
Are you guys getting excited?
So.
No, so that you do not have to get tickets. You can invite as many people as you want. They will need to go through security like they're going to a sporting event. I just have not heard back as far as what is allowed and what's not. So I would highly recommend them do like the whole clear bag thing like you do when you go to concerts and stuff like that. And they will have concessions available there. I just have not received confirmation if they can bring in water bottles yet. So that's some of the information that will be coming out to you once I know. I have an email out, but no one is listening to me. So story of my life, guys. No, I try. I promise to try. Yes. No, dress code, like not jeans.
White scrubs.
No, that actually was a school that did that, but.
That's how my fitting was. I could bring y'all a picture. I'm just kidding.
No, just dress nice, like what you would wear to like a wedding, I guess. Like, doesn't have to be super formal, but just, I mean, guys, like I'm sure like nice jeans and like a polo is probably fine.
People wore all sorts of things.
Yeah.
Like, I mean, some people got really dressed up and had really nice dresses, and some
Yeah,
guys
like,
wore suits.
it's your
but
moment, whatever you want to wear to have pictures with your family. I am arranging for a photographer to be there, like similar to commencement. So, just whatever. Just, I would say for shoes, you can walk in those big heels, more power to you, but without knowing how that tarp is going to be, if it's going to be slippery or like, just err on the side of caution with that, because I do not want anybody falling in a dress with their heels and having a whole wardrobe malfunction.
having
So-
to utilize your nursing skills.
Yeah, so let's just keep that in mind. Just be comfortable, but it's an occasion. It's not just I don't know, not just another day. Yeah, most schools don't go this big. They usually have like a classroom and they give you your pin, and but that's usually what they do.
Yeah, mine was held in the atrium of Pikes Peak Community College, or State College now. So
Yeah. So we try to make it an event.
Yeah.
Any other questions? Yes. What?
yes, you guys. So you guys will have your. It's not the headshots anymore, because those humongous
Oh,
frames are like $2,000 to do. So we have gone to just a group photo.
Yes.
Which you can see the very first one when you go through the double doors, going down to the sim labs, is last year's traditional
basic.
class. We're still waiting on the accelerated class. You guys will have, the accelerated group will have their photo done probably June, July-ish, as your own cohort. Traditional is having theirs done next Wednesday, the 19th.
So watch for communications about the meeting spot for your photo.
So it's usually done on a day you guys are all here. No, not usually. It will be done on a day you all are here. And during that lunch time period, to make sure that everybody who wants to be in it can be in it.
I think last year they just did like CSU
Yeah.
like clothes or whatever. I don't know what they've decided
Yeah.
this year.
And it's not, there's usually not a charge for the students. I don't think we've, because that's been sponsored by Scans. So,
Good question.
I don't see why not. We haven't in the past. We'd have
Yeah,
to
fun-
figure out how
Fundraiser just to print them out.
to do the printing. We could figure out how to do that. We haven't done it, but
Good idea.
why not? We'll work on figuring that out.
Oh, and since I have you guys too, simulation, since class starts pretty much right away, your sims will probably start week 2. It's looking right now tentatively that the first global sim will be on May 30th. But I don't have confirmation, but just be prepared, it might be early. Yes.
65.
No, you will have 4, but 2 of them are on the same day. So you'll come for Sim A, which is 4 hours, and then you'll come for Sim B and C, which is your multi-patient. Each one of you get 20 minutes one-on-one with 2 patients to take care of. It's a very long day for all of us, but it's fun. But you'll be there the full day.
Well, then they have global sim too, though.
Well, yeah, but I'm just going over 452.
Oh, yeah.
And then you'll have your Sim D, which is another 4 hours. Then global, you will come to campus once for 4 hours. Usually it's not, but if anyone asks, you were. And then you'll have a second sim that will usually take place on a Saturday in June, and it'll be via Zoom or Teams. It's a telehealth sim because I didn't see the point in bringing you for another sim. for global. Global is different. It's not traditional sim. It's different. It's beneficial, but it's different.
And global is hybrid.
Yeah.
Whoop, whoop.
So,
Only come one day.
for the most part, your sim will be on Tuesday, Thursdays, or Fridays. There might be a global, your sim A might be either that Monday or Wednesday where you have that 4-hour block. I don't remember which time it is, but I try to make it to where you don't have to make a special trip to campus, but it just depends on the instructor. As you guys know, I have like no control and no power to things, so I try, but
She should have all the power. We
I don't
can
know
all
about
agree with that.
I would make everyone wear pink on Wednesdays. If I had the power.
Like one pink shirt, okay? That will be for graduation when you're wearing all your regalia.
Yeah.
I mean, if you
can-
wanted to wear a stole, you could wear that.
You can wear your stole. I mean, no one, the graduate students, they wear their like full regalia, but
Yeah, because they're being hooded.
they're getting their masters and their doctoral hoods. Oh, that's the other thing. You can't leave like until it's over. This mostly goes for the grads, but they always tend to just walk out. But I'm hoping to deter that a little bit since they're in the middle of the court now and it won't be as
It'll be a little more awkward.
hopefully.
You should put them like in between. Have like,
Put them in the middle.
yeah,
rows.
yeah, put put all the bachelor's people like around them to where it'd be really awkward.
See what happens when they try to give you power? All right.
Great minds, like,
That would be funny. Of course.
absolutely. Nothing foul though. You are representing the School of Nursing. But clever, go for it.
I need a volunteer to make a slideshow with all the information that comes from forms. If you're interested, just email me. I'm not putting anyone on the spot right now, but I'm going to offer it. I'm going to see the basics next. So whoever emails me, then
It's a
we'll
rush.
get it made. It's pretty easy. You just get access to my forms and then I send you all the data and then you just put it in. So
Plus, you get to learn a lot about your fellow cohort.
yeah. All right. Well, if you don't have any more questions for me, then I'm gonna run away now. And then go to Chem 106. Oh, why are you guys over here? I have to go to Chem next. I'm stupid.
Well, Chem is right here.
Oh yeah, it is. I'm thinking life science. Never mind.
Yeah.
All right. Yes. Oh.
Just
Oh my god, that's a long ass title.
it makes it sound like you have a lot of power. Is that what you said?
Thank you. All right. If you guys have any more questions, I'm gonna leave. If you come up with any other ones, email me or come to me. You know I live here. Great. Thank you, ma'am.
Of course. is what's necessary for these guys. Now, when we do surgery on a patient for either kidneys or urethral surgery, ureters, there's tons of different reasons why we would do it. Transplant, kidney stones, tumors, massive trauma, take your pick. It is painful. This is not something that patients are like, yeah, sign me up, okay? They can be open, laparoscopic, anywhere from, I don't know, 20 minutes to go in and do a kidney stone removal to 6 to 10 hours to do a trauma repair or nephrectomy. Patients, what do you think is the most important thing if you're taking care of a post-op patient who's had something done on their ureters or their kidney? What would you want to watch for? What? I know. Dentation. So yeah, so we're looking for that kidney, the output, right? Mentation is telling me how well that patient is being perfused, because that's telling me how are my kidneys happy. Now, if they've taken a kidney out, how well is that other kidney functioning? If they've taken one out and put a new one in, how well is that brand new baby kidney hanging out in there? Is it doing okay? Is it, what are we doing? Is it happy with its new home? Vital signs, we're watching for signs of shock. You can lose some blood in that retroperitoneal space. So we're wanting to pay attention for that. Watching for the dressing, catheter patency. They're usually going to have a catheter put in afterwards. Anything for like kidney stone, though, they may just have had a stent placed. And then respiratory status, a nephrectomy, anything like post, whether they're doing posterior or anterior, or they might do both. They might access both ways. It's painful. Give them pain meds. They also can get abdominal distension if they've just done laparoscopic. Get them up, have them walk, but give them pain meds before they're walking. Check bowel sounds for paralytic ileus. We need them to have bowel sounds, at least some, before we're giving them any fluids or food. And then they slowly progress to a regular diet. All right, acute kidney injury. Kidneys, like I said, are very particular. They don't like to go without fluids. They don't like to go without perfusion. And we have 3 different ways that we can have an acute kidney injury, or AKI. This is a rapid loss of kidney function, where we have a rapid rise in creatinine, a decrease in urine output, and an elevated BUN and potassium. And does anybody remember what azotemia is? Nitrogen, yeah. So it has a high mortality rate because kidneys do a lot for us. In addition, what's causing that can have life-threatening complications. And this is the primary cause of death when infection is involved. So there's 3 different ways that this can happen. We can have pre-renal injury, intrarenal, and post-renal. The kidneys in pre-renal are injured because something happened before the kidneys. That's why it's pre-renal. That means that somewhere above the kidneys, there was decreased blood flow to the kidneys. This can be from severe dehydration. It can be from heart failure. It can be from decreased cardiac output. It can be from pressure from portal vein hypertension, from liver failure. Take your pick. Something is keeping blood flow away from the kidneys. So it's happening before the kidneys, pre-renal. Okay, so that's the first way that our kidneys can be sad. The next way is intrarenal. Something has happened inside the kidneys that has caused damage to them. Prolonged ischemia, nephrotoxic drugs. Hemoglobin has been released from hemolyzed red blood cells. Myoglobin has been released from necrotic muscle cells. This is what happens when your patient has rhabdomyolysis. Acute glomerulonephritis, systemic lupus. That is intrarenal. It's happening at the site of the kidney. And then we have postrenal. This is where the blockage is happening somewhere after the kidneys. So this is where we have some sort of mechanical obstruction to not allow urine to leave. We can have an enlarged prostate, we can have a kidney stone, we can have a tumor. And it's causing that backflow, causing hydronephrosis, which is then causing damage. Now, if you go more than 48 hours with hydronephrosis, you have now likely caused an acute kidney injury. Well, gee, how do you know if you've gone 48 hours with hydronephrosis? You don't. I mean, it's not like we do a CT scan and the kidney goes, I've gone 47.5 hours with hydronephrosis. It's not that polite. We don't know. We only go based on like H&P and what the patient tells us of how long they've had their symptoms. So, all right. So this is a need to know situation. Okay. Need to know. Know this, love this, embrace this. Here's another way to look at it. Pre-renal, intrarenal, post-renal. Know this, love this, embrace this. Okay. All right, I'm going to put this into we're going to apply this real quick. So Jesse, he's a 37-year-old man who fell off the roof of a house he was constructing. He has severe lacerations to his face and left leg with sustained blood loss. What type of kidney injury is he at risk for? Pre-renal, absolutely, because the blood's just not getting there, right? So our shock patients are at risk for pre-renal injury. And why? Blood loss. Now, how do we know if he is at, what signs and symptoms for renal involvement would we assess for? What do we want to know? Output. Yeah, absolutely. Output. And then what's next after that? What labs? What labs? BUN and creatinine. Yeah, absolutely. BUN and creatinine. Okay, so this is also a need to know situation. The rifle definition. The rifle definition tells us how bad is our acute kidney injury. So we have our patient who is initially a risk for acute kidney injury. And what that's going to look at is increased creatinine, and that's 1.5 times their baseline. or their GFR is decreased. That's their glomerular filtration rate. And then what is their urine output? If their urine output is less than 0.5 mLs per kilo per hour times 6 hours. That's really low, right? Because initially we'll have this oligorrheic stage of acute kidney failure, or acute kidney injury rather. That patient is barely peeing. They're barely peeing. Then they actually have the injury. That's 2 times their baseline of creatinine, or their GFR has decreased by 50%. Now we've done our urine output for 12 hours is decreased. Oop. For failure, we've jumped to the creatinine as 3 times their baseline. Or GFR is decreased by 75%. And now we've gone 24 hours of decreased, or they haven't peed for 12 hours. And then the loss is that persistent acute renal failure, that complete loss for 4 weeks. And then we end up with acute end-stage renal disease is for more than 3 months of that last one. So this is giving us an idea of what's happening. Where is our patient? We want to capture them here at this very first part, that risk part, before we progress. So oligorrhea, urine output less than 400 mLs per day. We generally see this within that first 1 to 7 days of injury. Hypovolemia may exacerbate this. And then because of that decreased urine output, the body is trying desperately to hold on to any fluid it has. So we have fluid retention too. We have distended neck veins, abounding pulse. They're full of fluid. We end up with some hypertension, fluid overload. Normally, the kidney can concentrate urine to 800 to 1400 milliosmolality, I think is how it, yeah, per kilogram, yeah. And with excess fluid intake, they end up changing it to 40 to 80 milliosmolality. So we see those changing based on what's going on with the patient. During this oligorrheic phase, they are at risk for metabolic acidosis because they can't secrete their hydrogen ions. Serum bicarb, that production is decreased. We may see them in Kussmaul's respirations. They can be hyponatremic during this time because when they are able to pee, they're peeing off sodium or excreting it other ways. But they're hyperkalemic. When we talk about peaked T's, these are peak T waves. This is super scary. You do not want to see this on your EKG. Your patient also, leukocytosis. They're at risk for urinary and respiratory tract infections, or that may have been what brought them in the first place. There's our beautiful elevated BUN and serum creatinine levels. And then because they have this excess waste floating around, fatigue, difficulty concentrating, altered mental status, so far as to seizure, coma, death. Like, this is not a good place to be. They are not doing well. Well, then we get super excited because we go from barely peeing to diuresing. And they start to pee 1 to 3 liters a day, as much as 5 liters. And it is not because of stuff that we're doing. And in this case, the kidneys are not concentrating jack. They are just dumping. Because guess what? They couldn't do, like, they are broken right now. So they are just peeing everything out. This patient can become hypovolemic. We can have severe hypotension because when you pee out 1 to 3 liters a day, man, you're gonna drop your pressure. They're gonna have alterations in acid base because they're peeing out their sodium, potassium. They can become super dehydrated. I mean, they're just, everything's coming out. Then hopefully we get to the recovery phase, which can be the diuretic phase is anywhere from 1 to 3 weeks. Then we have the recovery phase, which is up to 12 months if the kidneys are able to recover. This is where we slowly start to see that GFR come back. And it's like, yep, I can do this. I can do this. The BUN and creatinine slowly start to come down. This is all depending on, did we catch it early enough? And did we make interventions quick enough to give those kidneys a chance to recover? I'm gonna skip over this. Okay, so how do we check to make sure our patient doesn't end up with an acute kidney injury, or if they are potential for acute kidney injury? We need to do a thorough history. We need to make sure that we are checking creatinine, BUN, electrolytes, and a urinalysis, because we need to know what's going on with this patient. A renal ultrasound can check to see if there's any abnormalities, if they have something going on, either intrarenal or post-renal. And a CT scan, guess what? Do they have a stone? What's happening? And then potentially if you're dealing with like a nephritis or glomerulonephritis, then we can find out if they need a renal biopsy. Diagnostic studies, there is contraindication for contrast medium. Why do you think that is? It's super hard on the kidneys and they're not going to be able to filter that stuff out, right? We want to avoid those nephrotoxic drugs whenever possible. In fact, MRI or MRA contrast, the gladiolin medium, could be fatal for this patient. And then for our patients who are taking metformin, they may need to be switched to a different medication depending on how severe their acute kidney injury is, because metformin is so hard on the kidneys. All right, quick question. Which assessment would indicate to the nurse that the patient has oliguria related to an intrarenal acute kidney injury? Anybody want to venture a guess? You're going A. Should they, I even put what the normals are. Yes. Thank you. Maybe it was supposed to be. Come on in. Oh, sure, then I'll, you can, and then I'll grab your guys'. No, you're good. Yeah. Okay, she's waiting for somebody else. Okay, so what else do we do? Eliminate the cause. What happened in the first place? How do we make sure that the patient is not having issues? And then we want to manage the signs and symptoms. Adequate. Yeah. Yeah. Hold on, let me read my. Says the urine specific gravity and oliguria of intrarenal acute kidney injury will be fixed at 1.010. This value reflects tubular damage with loss of concentrating ability by the kidneys. That's what the answer says for me. I will have to Google that more. This came actually from the textbook. It's too normal. This is the one time it will always be. Interesting. Interesting. Okay. Ensure that our patient has adequate intravascular fluid volume and cardiac output. So we want to make sure that we're not causing any other type of kidney damage. So depending on whether we have intrarenal, prerenal, intra, or postrenal damage, what's happening with our patient? We don't want to cause anything else. And then we want to ensure that our patient has, that we're monitoring our fluid intake. The fluid restriction calculation, we look at all fluid losses the previous 24 hours and add 600 mLs. That's how much your patient would need, would have for their fluid restriction the next day. So anything that they lost, that would be urine, diarrhea, emesis, blood, and then we add 600 for insensible losses like diaphoresis or respirations. And then that would be what they were allowed to take in the next day. All right. We need to make sure that we are watching their hyper K. We know that we can move that, that potassium into the cells with sodium bicarb and with insulin. However, we do want to not drop that patient's blood sugar. So if we're giving them insulin and they're not a diabetic, that would have to be used very cautiously. So we'll use sodium polystyrene sulfonate. For those of you guys who have had that sim, did y'all have fun saying that? Sodium polystyrene sulfonate. That is K-exolate. One of the most important things with K-exolate, you have to listen to bowel sounds before giving K-exolate. Because guess where this works? In the bowels. Okay, K-exolate works in the bowels. It binds potassium in the bowels so your patient can poop it out with diarrhea. Okay, so if you are giving that, you have to listen to bowel sounds, because if your patient does not have bowel sounds and you give it, you can cause a ton of damage. So please, please, please listen to bowel sounds before you give anything that is acting in the bowels. Okay. Oh, this is gonna be quick. For continual renal replacement therapy, this is really a quick treatment for patients who have acute kidney injury, where we're removing uremic toxins and fluids. It's like mini dialysis where we're doing like a stopgap between dialysis, but it is over 24 hours. So our patient is constantly on it and it can be used with dialysis. But a patient who has life-threatening manifestations of uremia needs to have a more rapid treatment. This takes way too long. We do need to make sure that we're monitoring our patient for fluid overload, for elevated serum potassium levels. So your patient needs to be on a monitor because of those peak T's can give you that even before you draw labs. Metabolic acidosis, watching for the BUN and creatinine levels because that's what we're trying to fix. And then monitor for, we could also do peritoneal dialysis, but it's not as frequently used anymore. Intermittent hemodialysis, as well as continual renal dialysis. This does pump slower than regular hemodialysis. It's continuous rather than intermittent, and we need to make sure we're obtaining weights. We monitor, document lab values before and after we are doing our patient, because they're doing it in 24 hours. So, and then care for the site to prevent any infection. Tons of nutritional therapy needs to go in with these patients who have any kidney issues. They need to have adequate caloric intake, primarily in carbohydrates, and restrict sodium, potassium. Phosphate, it's a terrible diet. They will not like it. There's nothing to order on the menu. So oftentimes they'll end up with enteral or parenteral nutrition if they're not eating. Same thing for just acute kidney injury management, vital signs, daily weights, strict I's and O's. Look at that urine. Is it okay? Is it gray? Does that be really bad? Oral mucosa, are they dehydrated? Are we seeing that within their oral mucosa? Lung sounds, that's going to be one of your first clues if your patient is, if we're oversaturating them with fluids. Heart rhythm, monitor those lab values and diagnostic test results. Some clinical problems we've talked about: electrolyte imbalance, fluid imbalance. That can be pretty nerve-wracking to be sick like this. Health promotion, working with them on how to avoid this happening again. Tell if she's coming in or not. All right, and then for implementation, again, working on those accurate I's and O's, daily weights, assess for hyper or hypovolemia, and potassium or sodium disturbances. All right, for food for thought, what risk factors contribute to the development of chronic kidney disease? So we will be talking about that on Monday. Don't leave yet. I'm getting the Parkview people. You still have 7 minutes that you owe me.
No. Oh, I don't want to scare the light. There's a bright light. Oh, bright light.
Bright light.
Yeah, bright light.
Over here, so I'm not gonna
That's why y'all so tough.
That's what we'll do is we're just gonna stand here and wait.
There we go. Now it won't be shining in your eyes.
No, oh, Bella. Okay, now we're going to start measuring.
Hi, everybody. Thank you for letting us sneak in. We just want to take a few minutes of your time. My name's Maggie Welty. I'm the ACNO at Parkview. And so we are here to, number one, congratulate you on microphone.
No, you're doing good.
Oh, okay. I just thought I heard a microphone. I can hear myself. That's weird. Okay. So we just wanted to congratulate you on getting to this point. This is so exciting. And then also we're 100% here to ask you to come work at Parkview. This is such an exciting time for you. You know, personally, I graduated from CSUP and I was a nurse extern there when I was in nursing school, and I've worked there ever since. This part of your career, this next step, you're going to meet some of your best friends for life. Your work family becomes your family, and a lot of you are going to find places that you love to work in nursing, some that you hate to work in nursing, which is also okay. That's the cool thing about nursing. But we have some little swag. Jackie's going to talk to you about applying. We can start onboarding you, and before you actually take your boards, we have an amazing nurse residency program that started last July. So it's so awesome that we want to continue to support in growing you as nurses, getting you the education you need to become strong, confident nurses. So really, we are just here to say congratulations, and we have a spot for you. So I have to sneak out, but these gals will do their thing. And if you ever have any questions, please just let us know. So, thank you.
Congratulations. This isn't the whole class, right? There's more of you, right? Is this the whole class? I was looking for somebody that I knew and I don't see. But anyway, I wish she's a son person. Anyway, I'm Jackie Cano. You may have heard my name. You may have already applied. How many of you have applied at Parkview? Nice. Okay, have you heard from me yet? Okay, because I'm feverishly working through all the applications and trying to get everybody interviewed if you haven't interviewed yet. So now's the time to apply. We do have a cohort that starts in July, so you graduate in May, you qualify to get started in that cohort. So if you're not quite sure where you want to be, we want you to, just go online, reach out to me personally if you want, and I can kind of chat with you and give you some direction about great areas for you to work. But we do hire undergrads throughout our facility. A lot of you might want critical care and ED, so those are popular areas. I do want to let you know if you are applying for the ED, those positions right now, we're looking at the current ACTs that work in that department that will transition into the positions that we have posted for the ED. Critical care, we have a lot of ACPs that are already in that department as well, but we might have a few more openings. So go ahead and apply there if you'd like, and we'll be scheduled for some interviews. We have 5 med-surg units, awesome foundation to get. So each one of our med-surg units has a little bit of a specialty tied to it, whether it's bariatrics, stroke, orthoneuro, we've got oncology, cardiac telemetry. We have an off-campus orthopedic hospital. So we're hiring new grads in all of those areas. And we'd love to talk to all of you about that. Our residency program is kind of new to us. We joined UC Health last March, so we've been on board now for a year. And so we have a cohort starts July 21st. If you don't quite meet that cutoff, that's okay. We could still interview and offer now, and then we can push you into the August cohort. So the July and August cohorts will be our busiest months, but we have quite a few spots, so we can get you in there. Just kind of waiting on you to be able to get your degree conferred for us, and then your license.
So this is our accelerated group. So these guys all graduate, well, they'll finish in August or end of July.
I thought this was your May grads.
Nope, this is our, they
Which
will
is-
walk in May,
Okay.
but graduate, finish in August.
All right.
So
That's
what
fine.
would the time frame be for these
You
guys?
can apply now. You don't need to wait, so we're really
Okay,
proactive. So if you see a spot that you want to apply for, go ahead and get in there and apply. And then we would just look at onboarding you and graduate in August. So you would go into our October cohort. So yeah, thank you for letting me know that. I was thinking it
so
was,
plenty of time to be able to get your degrees conferred, take your NCLEX, because you're not gonna wait.
but you don't need to take your NCLEX before you get an offer.
There you
So
go.
we do want you to interview before you even have that date. And then we'll just patiently wait for you to get your license. So yeah, any questions for me? Yes.
Couple of questions. So I saw online, there's some that say, grad residency, and then there's some that say, fellowship. What's the difference?
So the fellowship, we only have very few posted. So you'll see one posted in, well, right now I have one posted in women's. So for a fellowship position, if you don't have any experience as a nurse yet at all, but you have 6 months as an RN, you would qualify to go into a fellowship. So you wouldn't quite qualify for a fellowship yet. So you have to have 6 months of experience. But once you get, our residency program is a year long. So if you get an offer, you have to stay within your department for a year, and then you can put in a transfer. Say you're 10 months down and you see a position open that you're really interested in, then you could apply for it, get interviewed for it, and if they're willing to wait until your residency is over. But we do like you to stay in that residency for a full year. So that's the difference. So we usually post, and fellowships are a little new to Parkview too, but we usually have them in women's or in the main OR where they're going to circulate, do that type of a position. So if you see those posted, just be sure to look at the postings. If it says you have to have 6 months of RN experience, then you would want to be sure you have that before you apply for it. Any other questions?
The second question I had, if there's some that don't have like residency on it, can we still apply it to those?
You'll want to apply for the new grad position. So let's say RN new grad. And the difference between UC Health Parkview and UC Health Colorado Springs up north, they only post one requisition. So one position, everybody applies to the one position, and that recruiter works through all of them, filters through, gets the interview scheduled, and then she'll just assign you to whatever position that you are offered. So if you interview in 4 areas and you get 4 offers, then the choice would be yours. At Parkview right now, we're going to be converting to that one requisition, so where everybody will apply to the one, but right now we have positions posted throughout the facility. So where you see a new grad RN position posted at Parkview, that's where we're hiring. Does that help? Okay. And yeah.
I know you said like critical care and ER and things like the ACPs and everything. Not like the rest.
Well, right now, just because those are really popular areas and we've hired ACPs in those areas, those are kind of the first ones we're going to look at because they've been in that department and we know they're graduating and becoming an RN. That's not really the case in all the other areas. You don't necessarily have to be an ACP to move into an RN role. So you actually don't have to do that at all. But if that's something that you're wanting, you can't, because since you're accelerated, you could apply right now to a critical care ACP position or women's or wherever you see one of those positions. You get onboarded as an ACP, you graduate in December, then you'll be the first ones we're going to look at for that department.
You'll just have to break that to Anna. I won't tell her.
So I want them to talk as well, but do you have any more questions related to employment and when to apply? Yes. Yes, you could apply now. Yes, and are you all done with MedSurg 1? Or, okay, so you all qualify right now, even if you were just in the course, you would qualify for an ACP. So if you're interested in an ACP, you could apply right now for that. And I'll reach out to you, get you scheduled for an interview, and then you would apply for an RN as you're getting closer to graduation, 3 or 4 months before. But you could apply for an RN right now too. Any more employment questions? Okay, these ladies are, oh, okay.
So I was kind of playing with the idea of mobile after I graduated, and I'm curious, like, UC Health is one of the largest healthcare system in the state. How might that break down, like, line wise, to somewhere like Parkview, knowing that I might not be on like the top range?
So you would have to go through a year of residency if you wanted to apply for a new grad position. I mean, you're not required to stay. If you want to resign, you can resign and go somewhere else. But this is also the way it works. Say you got hired on, you're in the residency program, 6 months in, you decide you're going to resign, maybe go do something different, go somewhere else. When you come back, our requirement is that you do a full residency year. So if you leave and you come back and it's been 3 or 4 months, you still have to go back into a new grad position to finish the year residency. Does that make sense to you? And I'm not sure if I quite understood your question.
You would like to move, is that what you're saying?
You know, to Grand Junction or somewhere else.
So it's just like a transfer
Yeah,
within that first year.
Okay, so you would still have to have, if you worked in Grand Junction and you wanted to come here, it's still a year long, regardless of where the UC Health position is that you get hired to. You can transfer 10 months down the line, you want to apply, like I said, for another area, you can, but you can't transfer until that year's up. Unless you get, we do have little case by case scenarios that we would look at. We would need CNO approval and some, different things like that. We would look at it like that. Yes.
So in order to, like, let's say work at UCL that's like a new grad RN, like to be employed at UC Health, you have to do this undergrad residency to just work as an RN at UC Health.
Correct, unless you go somewhere else and you get a year and a half experience and then you come back, then you're qualified. You just have to have 6 months experience to work in an experienced position unless you get hired as a new grad at UC Health. Okay. Any other questions? All right, these lovely ladies are going to tell you a little bit about the areas that they work at and where they started.
We'll go.
So 7 minutes left.
I was gonna say, we gotta.
You're good.
They have good questions. Yeah.
Great questions.
So I'm Kim Filson. I'm the nursing director for acute care at Parkview, Maine. And so acute care is a great place to start. It's also a great place to stay. It's a lot of your med surg units. Within the realm of acute care, you have med surg, trauma, oncology, ortho, float pools in there, stroke. So it's a bunch of the floors within the hospital kind of fall under the realm of acute care. I actually graduated from CSUP as well, and I did the accelerated nursing program. So I've been at UC Health Parkview going on 11 years now. And I started out in float pool, and float pool is a great place to start because if you don't really want to know, like kind of like, I want to do this for sure, it gives you an opportunity to see a bunch of different areas. The thing about float pool is you just have to be a very flexible person because each shift is different, which is great for some people. And other people like to know I'm going to the second floor and I'm going to be there all day, every day for my life. And that's fine. So you just kind of have to make that decision if you want a home or if you kind of want to float. But no, you guys are doing a great program. After I went from float, I advanced into the nurse manager, the associate nurse manager on one of the floors, went to a nurse manager role, and now am in a director. So we offer a lot of growth there. So if that's kind of a direction that you're looking to go into, there's always opportunities for that. And the best thing about it, even in our role, we still love to be involved with our frontline staff, and I still do all the business. I just kind of get to do it in a little bit different of a realm. So congratulations, and we look forward to all of your applications.
I'm Andrea Wade. I have met several of you, either at clinical or I worked with you at Parkview. But I'm the Director of Patient Services at Parkview Pueblo West. And then I'm helping Raylene a little bit on 4-H workout. I've been at Parkview, July, it will be 17 years. I started there as a nurse student extern, which is an ATP now. I started in healthcare as a psych tech, so I did that for 3 years prior to going back to nursing school. So I've been in healthcare for almost 20. But just to piggyback on what Kim said, it is a great place, and ultimately our goal for all of you is to find your fit, find your passion, take great care of our patients, and of course, support you along the way. So, whether you come or if many of you are already there, helping you to be successful if you have questions or anything like that. And the great thing I think about that whole residency program, we used to say, okay, you're an NSC, and we're going to give you 3 weeks on the floor and you're ready to roll. But now it's like a 10 to 12 week orientation, plus you have that ongoing support for the full year. So it has been, I think, just an outstanding thing for everybody involved. And you get to meet different people from other hospitals. So you go up to Memorial for that lecture once a week. Not once a week, sorry, once a month, thanks, right?
It's okay.
But, and meeting people from areas and really just growing those relationships, because you still, even though we have become part of this huge system, we are very much family friendly hospital. I feel like everybody knows one another, and we continue to do that. So we welcome you there, and hopefully we'll work with you. I'm also super proud of everybody I've worked with in construction. So congratulations.
All right. I will just take a little bit different turn, but not a lot, because what the girls said, absolutely. So I'm Raylene Wetzel. I go by Ray. I know a lot of you. I have 2 ACPs that have joined us, and then I know a couple other from working there. And as Andrea said, it's very much, even though it says UC Health Parkview, we are Parkview. I have been at Parkview 22 years, the majority of it in critical care. I too was staff, nurse manager, director on 44 South, and then back to critical care. So Andrea is helping me right now. We need to divide and conquer. We have a lot going on in our worlds. So I truly am the director of all 3 ICUs, so CD, medical, and neurotrauma, and then 44 South, which is our location. I don't know what else to add because the residency is amazing. And we are super proud of all of you. We would love all of you to come work with us because, as you can see, if you add up our years, I mean, Jack.
Oh, you guys want to know how long?
Yeah, Jack.
Longer than any of you were thought of.
But
March 3rd was 42 years.
yes,
Oh
so,
my God.
it's
It's hard to believe, right?
Yeah,
I raised all these kids.
she did raise us, and so if you
And I
add
want
up
to
our
raise more.
years right here, I mean, there's a lot of longevity, and that's what we're super proud of. So congratulations to all of you, and we would love you to join us if you aren't already with us for a few years. Thanks for
I was born
having
at Parkview and I started when I was 12.
us. Yes, yes. Jackie is amazing.
Yeah, call me. If you haven't heard from me, it's not that you're not going to, it's just juggling a lot. Try to get to all of you as soon as possible, so.
Just because I feel like this is super important and I don't think we talk about it enough, but Josh, I don't.
Oh, absolutely.
So sometimes there's that fear of commitment. This is also why I started a float pool and worked there of all my bedside nursing was a float pool. Didn't want to commit to a floor until I got older. You can do a job checker. So if you're toying with the idea, I really love this area, but I don't really know what it looks like. Jackie can help you with that. So you can come in, shadow for the day, set it up. That way you kind of get the real feel of what it would look like before you commit to that area. So that's another option.
If you get 4 offers and you want to shadow in all 4 areas, just so you can make that final decision, you can do that too. It's usually a full day. Or a day and a half. Half a day.
After nursing school, your brain's gonna be like, I don't know. So
Yeah.
yeah, we get it. So we want to make sure that, again, that you have all the knowledge. Thank you, guys.
Do you need help here? Do you need help? Those are my readings. Yes. Take eyes. Oh, so too.